Good morning. Thank you for joining us today. My name is Brandy Jensen, and I am the Director of Programs and Services with the Brain Injury Alliance of Iowa. And today I have the pleasure of sitting down with Dave Anders, who is the Director of Therapy at On With Life in Ankeny, Iowa.
Hey everyone. Thank you for having me. Appreciate it. Looking forward to talking a little bit about cognitive rehabilitation with all of y'all today. It's a big part of what we do in brain injury rehab, and of course an incredibly important topic. As we look at the recovery process after acquired brain injury.
Awesome. So tell us a little bit, Dave, about what cognitive rehab is and what does it encompass?
So, I think maybe as a precursor to talking about what cognitive rehab is, maybe we need to talk for just a minute about what is cognition, right? What if we're going to rehab cognition, we have to know what we're rehabbing in the first place. So, when I think about cognition, and when we as a field of brain injury rehabilitation think about cognition, there's really sort of three subcategories. And I almost think of these three subcategories as like a Venn diagram, like they overlap onto each other. And the three basic categories are: number one, your traditional cognitive skills. Number two, language. And then number three is emotion. So if you think about those three broad categories sort of overlapping and influencing each other, that really sort of encompasses what we're talking about when we're talking about cognition and interventions under that cognitive rehabilitation heading. So when we think about traditional cognitive skills, we think about things like attention. If I think bottom up, the skills that sort of layer on top of each other, we think about attention, we think about memory sort of layered on top of attention, and then we think about executive functions and things like visual spatial perception under that traditional cognitive skill category. Language and communication, of course, is that second category, and then emotion. And some people might be a little bit surprised by the idea of emotion being lumped under the idea of cognition or cognitive rehab. But when you think about emotion, emotion influences thoughts, and thoughts influence emotion. So your cognitive function, your ability to use and respond to cognitive rehabilitation principles and interventions are highly dependent on what's happening from an emotional standpoint. So emotions to some degree have to be a component of what we think about when we think about cognitive rehab. So understanding what cognition is, then thinking more specifically about cog rehab, we're thinking about evidence-based interventions. And those interventions fall really under three categories. There's a pattern of three here. The three categories that we think about in terms of the types of interventions that we do in cognitive rehab. First, there's a restorative sort of heading, right? So we've got a certain amount of impairment in cognitive domains or a domain, and the aim of the intervention is to help restore that function, to make the memory better, to make the attention better, to make the executive functioning better. So we have that restorative category. The second category is really compensatory types of interventions. So compensatory interventions are all about really reducing the impact of ongoing impairment in the various domains. So I have significant memory impairment, and that's an ongoing challenge. So I'm going to use a compensatory strategy of some kind, whether it's using sticky notes, whether it's using reminders on my phone, alerts, a memory journal, or a daily schedule. So that's a compensatory. Those are compensatory strategies, compensatory interventions that sort of help you function better in light of ongoing challenges. You can have both internal strategies that you use sort of in the moment. So one of my personal internal cognitive strategies is I talk through things, right? This weekend, I had to replace the valve and the hose on my grill because it's connected to my house, and so there were lots of connections and lots of steps. And so as I was going through that to sort of keep myself organized, I sort of out loud talked my way through what I was doing, and that's an internal cognitive strategy. And then there are external cognitive strategies, like I talked about earlier: use of your phone, use of a day planner, use of a daily schedule, use of reminders and sticky notes and those kinds of things. So we've got our restorative interventions, we've got our compensatory interventions, and then the third category that really doesn't get, I don't think it gets enough attention, is environmental strategies, right? How do we help the survivor and their care partners set up an environment where the individual can function at their cognitive best? And what this involves is often training care partners on cognitive rehabilitation strategies so that they can use them in that environment. So it's not necessarily anything that the survivor is using or doing specifically. It's more, how is that care partner setting that survivor up for success? So you've got those three categories of interventions, and then when we think about cog rehab, we have to think about um, sort of the stages that people go through in acquiring a skill or learning something new. And there are three, again, the pattern is three. There are three basic stages that people go through. The first is acquisition, and that's learning the skill. So learning how to use a memory book. And then the second is application. So in the structured setting, and I'm a speech therapist by background, so in my structured speech therapy setting, can I use that skill? Can I use that memory book? And with cueing from the therapist, can I get the book out and access the right sections of the book and access the information that I need? So that's the second, which is application. The third is adaptation. So that's, can I generalize? Can I take that cognitive strategy? Can I take that intervention outside of that highly structured environment and apply it in the real world? And that's really the holy grail when it comes to cognitive rehabilitation. Learning a new cognitive skill or cognitive strategy really is pointless if the only place you can do it is in that therapy session. It's all about, how do we make life better? So that's, when I think about cognitive rehabilitation, again, we think about restoration, we think about compensation, we think about setting up the environment for success, and then we think about, how do we go about the process of acquiring, applying, and adapting the skills that we're training. I think you're muted, Brandy.
Oops. Thank you. Thank you for that description. Who would be a candidate for cognitive rehabilitation, and who are the different providers involved in the process?
All right. So two questions: who gets cognitive rehab, and then who provides cognitive rehab? Um, I'll start with the first one: who gets cognitive rehab? So there's theory and then there's reality, right? So I'll start with theory. In theory, really anyone who has acquired cognitive challenges should be able to get cognitive rehabilitation. So we can talk about that in terms of acquired brain injury specific. So, obviously cognitive challenges are a hallmark of really all severities of acquired brain injury. Obviously that moderate to severe, it's a huge hallmark of that population, but we do also see cognitive challenges in the mild population as well. Your concussion population does often experience cognitive challenges, and especially those individuals who end up with persistent post-concussive symptoms. They're an example of really that complex interplay of emotion and cognition. Often the interventions for those individuals include both looking at emotional regulation as well as some cognitive rehabilitation techniques. Again, under that acquired brain injury heading, you think about not just traumatic brain injury, but also non-traumatic brain injury, like individuals who've had stroke, individuals who've had brain tumor, individuals who've had anoxic or hypoxic injuries. And then there's sort of a second category where you think about populations that have had maybe developmental or degenerative processes that have caused cognitive challenges. So there's some evidence for the use of cognitive rehabilitation techniques for individuals on the autism spectrum, for example. And then also individuals with various types of dementias and Parkinson's disease and those kinds of challenges. In theory, everyone under those categories should be eligible for cog rehab. Now, then there's reality, right, which is very different from theory. It's going to be dependent. The individuals who get cognitive rehabilitation, it's going to be highly dependent on their circumstance and their funding source. Quite honestly, on with life, on the inpatient side, we're paid per diem, which essentially means we're paid by the insurance company a set amount each day, and our responsibility is to provide the best rehabilitation that we can provide for that dollar amount. And so that gives us a tremendous amount of flexibility in terms of what we can provide. So we can provide cognitive rehabilitation without really worrying too much about the billing side of it, because it's the right thing to do, and it's the way that outcomes are better if we provide high quality cognitive rehabilitation as a component of the rest of their rehabilitation. So it's common for us to use cognitive rehabilitation principles and interventions on the inpatient side. Now you move to the outpatient side, whether it's at On With Life or any other outpatient rehabilitation provider, and it gets much more difficult because those are fee for service. And often, if not always, they require pre-authorization. So you have to say, here's what we're going to do, here's the interventions we're going to provide, will you authorize that? And in most cases, cognitive rehabilitation is either it doesn't get approved or it doesn't get paid, and it's incredibly difficult for providers to justify your reasons for asking for cognitive rehabilitation. So again, big difference between theory and reality, especially as you move farther out from the injury and are trying to access these types of interventions at the outpatient level. Now, the second part of your question was who does it? Who are the providers that do cognitive rehabilitation? And so if I stick with that more outpatient model, you've got the people I most often see doing it are speech language pathologists, occupational therapists, psychologists, neuropsychologists. That being said, again, very difficult to get approval, and reimbursement levels for what approval you can get are often low enough that it is a deterrent to provision of those services. So there are some real sort of systemic challenges to access, especially at that outpatient level. So, again, when I think about who should be providing it, and I don't like to use the word should, but I don't know what other word to use. In an ideal world, what would cognitive rehab look like? I feel like that list is way too narrow. Your SLPs, OTs, psychologists, neuropsychologists, I feel like that's much too narrow. Especially as we think about that third category of intervention, which is how do we set up the environment in a way that allows individuals to function at their cognitive best. Um, we need to, in order for good carryover of cognitive rehab principles and effectiveness, you have to really surround that survivor with individuals who understand the impact of the environment on cognition, and in turn, who understand the impact of cognition on function. So maybe I'll give you a couple of examples. A couple of years ago, I went to an ACRM meeting. And ACRM, the American Congress of Rehabilitation Medicine, they have a cognitive rehabilitation subgroup, a work group that looks specifically at cog rehab. And I went to a presentation by a couple of people who run rehab programs and who were challenged by really knowledge translation across the team in terms of cog rehab. So your usual model would be, I'm going to send a speech therapist, or I'm going to send my neuropsychologist to get this cognitive rehabilitation training through ACRM. And then that individual comes back and applies what they've learned. And what these organizations had found is that it wasn't working well for them. It didn't, just using cog rehab principles in your speech therapy session, and then not in OT or not in physical therapy or not down with nursing, that's not a great way to get that generalization, right? That adaptations, to get to that adaptation stage. And so the whole presentation was all about the ways that they went about integrating cognitive rehabilitation throughout the organization, rather than having it isolated to one or two specific disciplines. And I think about a couple of years ago, we had Dr. Wayne Gordon's team from Mount Sinai train on with life clinicians in the use of SWAPs, which is a problem-solving intervention, a cognitive rehab problem-solving intervention, and another intervention called MREG, which stands for emotional regulation training. And we did that with the neuropsychologist, the clinical counselor, physical, occupational, and speech therapy, rec therapy, music therapy, nursing representatives. And again, it was all about sort of embedding persons served in an environment where cog rehab just is part of what we do, irrespective of discipline. And just recently, there's been I'm on a listserv from that ACRM Cognitive Rehab Task Force. I've started getting some messages from that listserv that they're putting together a work group specifically targeting cog rehab knowledge translation to family members. So at the ACRM level, we're looking at better understanding just how important it is for families to understand how to apply cognitive rehab principles. So, I think the field is despite some of the funding challenges, I think the field is moving in the right direction in terms of how do we integrate cognitive rehabilitation and not think of it as this thing that is isolated outside of the person's life, right? That cog rehab isn't something we go into a little room and do on worksheets or do on a computer. It's something that's that is embedded into everyone's philosophy of rehabilitation.
I think that's such a valuable point that you make there. And it's exciting to hear that there's efforts in that area if they're going to be, especially, working with family members. I mean, it makes me think about the opportunity to really incorporate more of those skills and training in the service provider world as well, for individuals that are being served, in 24-hour sites, or with staff that are coming into their home, and the more success that they could see if they had those skills, working with those individuals. And it probably could prevent some of the extreme case scenarios that we see here in Iowa, where they have to go into higher level of care. That could be prevented.
Yeah, absolutely. And again, the holy grail in cognitive rehabilitation, well, in any skill acquisition, is generalization. And really, generalization, it's just it's really difficult in acquired brain injury, but it's particularly difficult if the only time we're getting the intervention is in a room with a therapist, right? If it isn't translated outside of that room and into the larger, that person's larger environment. So yeah, incredibly important. And with the funding challenges, I, I almost, I believe that it's incumbent upon us to sort of figure out how do we provide the best services for these individuals? How do we make sure that if there's evidence that this is a beneficial intervention, that they get it, no matter whether it's from an SLP or an OT, right? It's not about the specific discipline. It's more about how do we translate that knowledge to the broader spectrum of individuals in that individual's environment, so that um, they're getting a broader scope of opportunities to use those skills.
Absolutely. That's really insightful. I think it's important to remember that. I guess another question that I have is what kind of changes you've seen in the different approaches over the years, and advancements in technology and that sort of thing. What kind of impact has that had?
So I don't know how much of your audience cares, but back when I started doing acquired brain injury rehabilitation in the mid to late 90s. And back then it was very much it was an isolated thing, right? I pull you off into my little classroom, and cognitive rehab was worksheets, and cognitive rehab was computer programs, um, and it really wasn't integrated into what other people did, right? I go to PT and get my physical stuff. I go to OT and get my ADLs, or activities of daily living, and then I go to Cog Rehab and get my thinking skills stuff. And that was, quite honestly, one of the reasons why we ended up in the field of rehabilitation. It's one of the reasons why Cog Rehab ended up with sort of a target on its back from an insurance and payment standpoint, was that we were separating cognitive rehab from the rest of rehab. And providers were charging a lot for those in individual sessions and individual interventions, and then it later found out that it wasn't effective. Well, of course it wasn't effective. It wasn't integrated into the environment. And so Cog Rehab kind of got a bad rap, and again got that target on its back because of the way it was conceptualized early on. And now we're trying to claw our way back. Um, you know, we've seen I've seen a movement toward this more broad approach to what Cog Rehab is. I've seen a more broad approach to who provides it and how it's provided. And there's more of a holistic view of what Cog Rehab is versus sitting in front of a computer and doing computer games is probably isn't the well game-based cognitive rehabilitation versus actually doing it in real life, implementing those skills in real life, which is what rehabilitation is ultimately all about. So again, I feel like we're slowly moving in the right direction. Not that there aren't still funding challenges, and there is a place. It's not that there isn't a place for some individual work, right? Especially at that acquisition and application phase. I want to pull someone into an individual session, teach a strategy, and start to practice it in isolation, and then we got to get it out there. Though in those individual sessions, you just don't have the ability to get to generalization. So moving in that more holistic direction helps from a generalization standpoint.
That makes complete sense. So I'm curious, you have individuals that come into your inpatient program, make great strides, make great progress, they get discharged. I'm assuming that sometimes a year later, maybe 2 years later, or even sooner than that, they end up maybe back in your outpatient program.
Mhm.
Tell us a little bit about some of the things that you maybe see when those folks are out in the community and they don't have access to that continued level of rehab and probably lose some of those skills when they come back.
Yeah, yeah, I think some of the responsibility for avoiding loss of skill is our responsibility in terms of training families and making sure that families understand. In rehab we tend to spend a lot of time teaching people how to transfer, teaching people how to physically manage and physically help their loved one. And I think it's probably incumbent upon us in rehab to spend at least as much, if not more, time helping them understand cognitives, how to help their loved one from a cognitive standpoint. you
Yeah.
know the other the other thing that can happen at the outpatient level, sort of depending on your circumstance and depending on what kind of services you need, is that cognitive rehab principles can be integrated into other modalities. So, what do I mean by that? The the speech therapist, the occupational therapist, the psychologist that you're seeing on an outpatient basis may be able to, for example, I, as a speech pathologist, I can use a code for language. And yet, as I'm working with that individual on their language, I can weave cognitive rehab principles into that intervention, right? Language, both verbal language and written language, is the conduit through which many cognitive rehabilitation interventions are provided. So we think about things like verbal reasoning, verbal problem solving. There's a significant language and communication component to that. So I can justify certain codes and yet use some skill sets associated with cognitive rehab to provide what that person served needs in some specific situations. Occupational therapy, if you think about the influence of cognition on, for example, activities of daily living, like uh, cooking and getting yourself dressed and showering and self-care, you can use cognitive rehab principles and interventions to help people better complete, more efficiently complete, more accurately complete their activities of daily living. So, for example, I think about there's a specific intervention called predict perform. And what that intervention entails is essentially the clinician sitting down with the person served and saying, all right, we're going to cook a meal. I want you to predict how much help you're going to need. How many times do you think I'm going to need to cue you? How much physical assistance do you think you're going to need? And then you videotape the session, you go through, you complete the cooking task or the dressing task or whatever task you're doing, and you review it with that person served to see if what they predicted matched their performance. And then you make adjustments, that person served makes adjustments in what they're doing based on that feedback. So that's a cognitive rehab intervention, but it's being provided in the context of an ADL, an activity of daily living, so that OT can build that code that goes with ADLs rather than the cognitive rehabilitation, the cog rehab code. If you look at psych, if you're going to see an outpatient psychologist, emotional regulation, which I mentioned earlier, really is sort of a repurposed and finessed version of what's called cognitive behavioral therapy, which is a common psych intervention that they can get reimbursed for. So again, MREG is a cog rehab intervention, but it can be provided by a psychologist, and they can bill a more traditional code rather than the cognitive rehabilitation code. And the principles of MREG are the same as cognitive behavior, more traditional cognitive behavioral therapy interventions. It's just that MREG might be a little bit more better tailored to individuals with brain injury.
Yeah, that's very interesting. Thank you.
Mm-hmm.
You talked a little bit about the billing. Is there anything else you would like to add, just as far as what you've seen in insurance covering this?
Well, sometimes we can get initial authorization when there's someone's had a change in status, they've had a significant decline in status. If that change in status is identified and requested, and the cog rehab is requested by the physician, sometimes we can get it, though not very often, after someone has received a neuropsychological evaluation and that neuropsychologist has recommended cognitive rehabilitation. But it's it's a challenge, and it has been. Again, I've been in this field since the mid 90s, and since the early 2000s, it's really been a hard thing, and there just hasn't been a whole lot of movement on it, not without effort on a lot of people's parts, but it's been an ongoing challenge.
Definitely. Um, Great. Well, is there anything else that you would like to add? You've answered a
Oh,
lot of questions for us today.
yeah, I think, aside if you take the funding issue and set it aside, um, there are other barriers to access, and challenges that we have to sort of address. One is uh, access to professionals with expertise. Now, when you think about COVID in particular, one of the positive things that came out of COVID is access to telehealth and reimbursement for telehealth. So for folks in Iowa and more rural areas, they have some additional options from a telehealth standpoint. And there are aspects of cog rehab that can be done via telehealth. I think another one of our challenges is that we exist in a largely medical model, and the medical model of healthcare really values, if you think about the consequences of brain injury, there's three broad categories. You have physical consequences, cognitive consequences, and emotional consequences. And the medical model really values the physical stuff. How far can someone walk? How much assistance do they need to dress? And to some degree, the medical model devalues the cognitive side and the emotional consequences uh, of brain injury. Um, so we I think as a field have to get better at defining outcomes for um, insurance companies. We need to get better at defining outcomes for providers. We have to things like look at things like, can we change someone's employment status with cog rehab? Can we give them better participation in their life roles? Can we help them attain education? Can we help them participate better in their community? Can we improve their quality of life? Can we help maintain the care and health of care partners through cognitive rehab? Right? We know that in the long run, it's care partner burnout is much more highly associated with cognitive and emotional challenges post brain injury than it is with the physical stuff. So how do we keep them healthy? Um, so yeah, I mean, there's a host of challenges, but again, our responsibility in brain injury rehab is to be creative and to sort of figure out how do we get the evidence-based interventions to these individuals, despite sort of the barriers that are out there.
I think that's so important what you talked about there, because what we see at the Brain Injury Alliance of Iowa as well, a lot of that bleeds over into their abilities to continue on um, accessing work, retaining work, and accessing Social Security disability as well. So the individuals with physical disabilities do tend to have better access and outcomes with accessing Social Security disability determinations, and those individuals with more of the emotional or behavioral or cognitive difficulties struggle with accessing those benefits more. And then their ability to have success in employment goals is also impacted. So I think if they were to, if some of these outcomes with, if more individuals were able to access cog rehab in general, it would benefit them in the long run in so many other ways.
Absolutely. I would just do a quick plug for advocacy as well. There's that we have a lot of ground that we have to gain in terms of getting people access to uh, address both the cognitive and the emotional
Mhm.
consequences of brain injury, especially in the long term. And there's national advocacy efforts, on the part of the United States Brain Injury Alliance, Brain Injury Association of America, ACRM, Cognitive or American Congress of Rehab Medicine, ASHA, which is the Speech Therapy National Organization, AOTA, which is the National Occupational Therapy Association. They all have advocacy efforts for cognitive rehabilitation. Locally, we unfortunately with COVID, we haven't been able to do the Hill Day stuff, but helping our legislators understand the importance of those addressing those cognitive and emotional consequences of brain injury is always a part of what we do when we go and advocate on Hill Day. And then, I would just advocate to any providers out there to think about changing how we think about cognitive rehab, right? And making cognitive rehab intervention, the skills associated with providing those interventions, crucial skill sets in providers at all levels, rather than just something that only a handful of people provide. That's ultimately how we help our person served generalize those skills and have access to those skills.
Absolutely. It absolutely would make for better outcomes for individuals and in the long run get more people back to work and save money.
Mhm.
So it's thank you so much for sharing that information. Well, thank you for joining us today. And we'll be sharing this um, with our constituents, and let us know if you have questions. Have a great day.
Thanks, everybody.